Wednesday afternoon, but that's another story.
I hear you. I hear you. All right, we're going to get started now. Good morning, everyone. I'm Larry Boris with the National Association of Worksite Health Centers. I'm pleased to have you join us in our first Monday roundtable. This month's roundtable is on developing the business case for on-site and near-site health centers. Joining me today is David Breach from Marsh McLennan. David will introduce himself in a moment. I want to make sure everyone can see the screen. This meeting is being recorded, so you will have the opportunity to hear this discussion and presentation afterwards. We also will give everyone a copy of the slides. If for some reason you want to make a comment, you don't want it recorded, just let us know and we will turn the recording off. We do like to have these roundtables be as informal and pragmatic and open as possible. If you want to talk about some confidential information you just want to share with the group or you have questions about, you're welcome to do so. And again, we'll just stop the recording. But we wanted, again, the format here is David and I are going to do an overview of this topic, spend about, maybe 20, maybe 25 minutes. And then we're going to go around the table and invite everyone to share your questions, experiences, information, lessons learned, challenges, etc. on this topic, things that you would recommend others do. On the call and the roundtable, we have employers, we have providers, we have third-party vendors who manage centers, we have other vendors who support worksite centers. So we really have the whole industry available for the discussion. So it should be very interesting. So feel free to participate. We ask that you put yourself on mute until we get to the roundtable discussion side. But then we'll be glad to open it up. And as I said, I will literally call on everyone. So write down your questions or your comments or things you want to contribute during the discussion. So again, I serve as the executive director of NAWHC. I'm out in Phoenix. Our office is in Dallas. And I'll be joined with the discussion with David Breach, who is the Vice President of Worksite Health Consulting for Marsh McLennan. David, a little background, if you would, please.
Yeah, good morning or afternoon, depending on where you're at. Great to be here. Yeah, just really quickly. So I am the national practice leader for Worksite Health at Marsh and McLennan Agency. And just to unpack that slightly, so Marsh and McLennan is the big global risk management company, and we have several major business units. One of them is Marsh and McLennan, and so we sit in that business unit. We have a few other business units you might be familiar with. Mercer is another business unit within our organization. Oliver Wyman, a consulting firm, strategic consulting firm, at yet another. In terms of what I do versus what Mercer does, we do largely the same work that Mercer does in the worksite consulting space, but our focus is mid-sized companies, typically from 500 to 5,000, although we do have clients smaller and larger than that. So on a day-to-day basis, I work with our offices and consultants on anything and everything that's worksite, near site, virtual health. And so the topic we will be talking about today is a topic that I'm quite familiar with from the years that I've been doing worksite. Also mention I've been in the space for about 23 plus years, starting in, I guess, the year 1999.
Great. Thank you, David.
Yep.
All right, let's get started. So employers are already offering a variety of services to employees in their benefit plans. They cover treatment of injuries, they handle occupational health issues, identification of risks and screening programs, doing benefits and health education, chronic disease management, telehealth and virtual care, wellness programs, primary care, and a variety of ancillary services. For each of these things, what we find is people have to leave the worksite. And based on the studies that have done by NAWHC, we find people are gone 3 to 4 hours. They go home, they feed the dog, they don't come back to work. So what can you do and bring to keep people at the work site and productive? So a worksite center, an on-site and near-site center is a real opportunity to keep people at the worksite, give them a variety of services that with an easy access at little or no cost. And so in order to make the case to your C-suite or your city council or school board, we thought that it's important that you understand the value. But again, at the end of the day, it's about reducing costs and improving productivity. So this is a variety of situations that an employer or union might find itself in that would cause it to consider offering an on-site or near-site center. You may have some or all of these types of situations. You may have other situations or challenges that cause you to want to consider this kind of benefit. But we find that in our membership of over 100 firms, these are the kinds of things that come up over and over and causes them to first consider and then to expand the services that they have. David?
Yeah, so this slide, I wanted to just talk a little bit about, what we hear from clients who are interested in the space. So probably there isn't a week that goes by that I get a call from one of our Marsh consultants or salespeople or health management consultants with a new opportunity. And so, when we start to discuss this with our internal team or with the client, the first thing we're kind of interested in is what are they trying to accomplish? And so I've really kind of listed the typical things that we hear, and probably all of these are pretty self-explanatory and intuitive, but might just comment on a couple of things. Um, uh, so I think in today's world, what we typically hear, or clients we typically work with, they either don't currently have a clinic. And so their objectives are often different than clients that already do have a clinic, and for whatever reason, they want to try to optimize the clinic. They want to add ancillary services. They don't like their provider and they want to look for somebody else. So they're all kind of coming at it from a little different perspective. I would say this sort of speaks to clients that often do not yet have a clinic. So they're really in the data gathering stage. And so we have a nice, robust conversation about what they're trying to accomplish. I'd say in the last few years, every year is new and different, but a few years ago when we had COVID, a lot of employers with clinics were looking at how to address COVID through their clinic. Whatever that clinic was, they wanted to help figure out how to treat people, get people back to work where that made sense. Coming out of that, virtual health really took off. So most of the worksite providers really had very little capability in virtual health. But they spent the couple of hard COVID years really building out a virtual health platform. So access was really huge during that period of time, and still, I think, is for many people. Um, managing costs, that's always kind of on the table. When you talk to employers, that often is not the first thing they mention in terms of what they're trying to accomplish, but we usually work up to that, and that usually has some significant role in the initiative. I would also say we spend a lot of time on ROI, so as opposed to VOI. So some of these areas are really value-based initiatives, meaning it's really hard to quantify the value in dollars and cents, but they are nevertheless very important to the client. Other things are more amenable to to monetization. And that's kind of where the finance people live. So there's a strong desire to really be able to quantify, what this looks like from, a spend and save standpoint.
Great. The other thing I would add here is, you know, being able to offer benefits and services is great. And even having a worksite center is a wonderful benefit. But if people don't take care of themselves, this all goes for naught. It doesn't matter what's prescribed or what their physician or nurse practitioner tells them. If they don't follow, if they don't understand how to manage their drugs, if they don't know how to take care of themselves or use whatever device or equipment, or what kind of exercise or what kind of nutrition they have, they're having no luck. You're not going to help them. And one of the real value propositions, I think, for a worksite center that often is overlooked is, people see their doctor once or twice a year for 7 to 12 minutes, but they're at the worksite 1,000 to 2,000 hours a year. So there's a tremendous opportunity for a worksite center to be able to help people manage their conditions, understand them, be able to talk to someone on an ongoing basis, having a provider each day or several times a week available to help them, counsel them, to seek them out, to make sure they're taking their meds. You have a diabetic who could be on 5 to 12 medications. If that individual doesn't stay on that, they could lose their vision, they could lose their limbs, they could go on dialysis, they could have cardiac problems. You could really prevent and reduce risk by having a resource, a worksite center that does give people the chance to understand and manage their conditions. And then you'll be much more successful. And that, again, ties back to productivity and everything else we try to do here. David, you want to comment on the ideal employer, the items you have in the bottom?
Yeah, I mean, again, I think this may be largely intuitive to most of you. But I get the question a lot, especially from our consultants about, well, what's an ideal employer for a worksite health center? So we've kind of listed some of the things that are consistently important in terms of having a health center pencil out from an ROI standpoint. So you need some volume. I've got 1,000 lives, but which, if it's total lives, that maybe takes us down to 500 employees. I think in order to have a health center open a significant portion of the week, you sort of need to get to at least 500 employees for it to make sense if you're trying to keep it open 30 to 40 hours a week. Competitive industry. So some industries are super competitive, and worksite health is part of the competitive landscape. I think about technology companies, for example, who were pretty early adopters of worksite health. There are some other industries that are quite competitive in terms of trying to attract people in today's world and achieve the productivity they're looking for. So it can be really a valuable tool from a competitive standpoint. Culture of well-being. So a lot of organizations have a strong culture of health, and they're looking for something to really complement what they're doing and tie everything together. So for employers that are looking for that, the worksite health center can often becomes the hub of healthcare, at least at that location, if not the entire organization. I think that also sort of speaks to population health initiatives. So as Larry was mentioning, or I think at least inferred, in today's world, everybody's really focusing their worksite health centers on population health management and chronic disease management. When I started in the business, it was low acuity, routine acute care, keep people out of ER, but they did not want to do any primary care. And that lasted about 7 or 8 years. And then sort of things started changing slowly. But really in today's world, I think the vast majority of employers are really dialed into the mission around managing chronic disease. High chronic disease, we just kind of really mentioned that. And then self-funding. I mean, I've worked on some clinics that were not self-funded. where the medical plans were not self-funded. It can be very challenging to get everybody on board, meaning the carrier, and work out some of the administrative details. So self-funding really helps accelerate, getting things done.
Yeah, and I would say, frankly, we have employers as small as 200 in NAWHC, and we have a number of employers using shared centers. So if the employer does not have the capital or the space to actually have something on site, a shared center would still meet all of these opportunities and bring value to an employer. And that's a whole other presentation we can talk about another time. The other thing I want to again touch that David mentioned was on access. While COVID clearly emphasized the challenge of access, even today in metropolitan downtown areas, it could take you, 2 or 3 weeks to see a doctor, much less travel across the town to see one. And access is so key. And just a fallback, in my previous career, I was the head of the Midwest Business Group on Health in Chicago, made up of large jumbo employers in the metropolitan area, Chicago and Illinois. And we used to promote the idea every employee should have their own doctor and see a physician once a year as a base, and that'll guarantee their health. Well, what we find today when we look at how many people go to the worksite centers and how many of them have physicians, we're finding 40% or more of people who use a worksite center do not have a personal doctor. And so the worksite center becomes their sole medical home, their sole source of information and resources. So we can't assume as employers and purchasers that everybody's got a doctor or some local source of information. They may not have that. And so again, another real value proposition is access. David?
One more, I'm
Go
sorry.
ahead. No.
One more point on that. So, access has a lot of facets to it. Larry was really sort of talking about access to a primary care physician, but we're seeing access issues drive clinics toward expanding into ancillary services. A great example is behavioral health. So I remember it was probably 5 or 6 years ago. I had a client that was interested in expanding into expanding the services on site into behavioral health. And they wanted to know, well, how many employers really do that? So I actually called the largest worksite provider. I won't name names on the show, but I called the largest one and I said, how many clients do you have right now with on-site behavioral health? And the answer 5 or 6 years ago was five clients. Now, if you look at it today, it's probably at 205 or 305. And we all know, access to good behavioral health support and services is really very challenging. The other issue we're seeing a lot of is pharmacy. So don't know how many of you have been into a Walgreens or CVS lately. Oh, I wasn't going to name names, sorry. Don't know how many of you have been into a retail pharmacy lately, but that can be a very challenging access environment. So what we're starting to see is a lot of the worksite health centers, whether it's just a provider dispensing clinic or whatever, or there's a pharmacist, really expanding pharmacy into be able to deliver a lot more medications, including chronic meds at the worksite health center to help alleviate some of the access issues.
Great. All right, we've got a lot of information to share with you. So we're going to run through this, David. So here we go. So David, talk about health center considerations.
Yeah, so I've listed some of the key design considerations. Again, this is something we do with clients that are interested in a health center to really try to better understand their needs and what they're looking to accomplish. So obviously, we've talked about objectives. I won't read everything on here. I'll just kind of cherry pick a few things. So delivery model, acute versus primary care. Again, as I mentioned, the vast majority of worksite health centers now are really looking to do primary care. A subsidiary question that comes up is how do we staff the clinic? And so there's often at least a consideration around MD versus NP led clinics. MD led clinics are a lot more expensive from a staffing standpoint. And so there's some trade-off in terms of, scope of practice versus cost. That's always something people spend some time thinking about. And sometimes it's just a cultural issue. I've had clients that say, a mid-level just won't work in our culture. And so, respect that and understand, that's the way they feel. Others love mid-level providers. And so those work really well for people.
And I would just jump in and say 60% of our members' centers are run by nurse practitioners or physician assistants.
Yeah. Yep. And I would say in the mid-market, it's a much higher percentage. So, in the market that I live in every day. Occupational health services. So historically, there was this bifurcation between acute primary care and occupational health. So the safety department or the risk management department historically has had, and I would say still the majority had ownership over occupational health. And then HR typically had ownership for primary acute care initiatives. And we're starting to see that blend together much more than ever. Really starting to think about sort of strategic implications, population health implications between personal care and occupational health. And so that's driving a lot more opportunities. Probably 75% of the new opportunities we see are interested in both sets of services in some form or fashion. So that's been a big change in the last few years. I think COVID catalyzed that to some degree, but it's been building. Shared clinics, Larry mentioned shared clinics. So that's a pretty hot topic. It's really just getting up a pretty big head of steam. And shared clinics can be really useful where either you don't have a sufficient number of employees to cost justify a health center on site. But it can also be a situation where you might have an on-site clinic in a large location, but maybe if you're in a metropolitan area where there are shared clinics and employees work in smaller locations around the metro area, shared clinics might be a nice complement to the on-site health center. So we're seeing more employers kind of look at those dynamics, as well as just, kind of finding better primary care for smaller populations around the country. So that's been a pretty hot item.
Okay. Let's go the other way. So when we're talking about what your options are, you have to consider what you have. And David covered some of this already. But these, again, you have to focus. If you've got your population living in the surrounding suburbs and your operation is in a metro area or downtown or far away, you might want to wonder, will people actually come? Will they use the center? Well, dependents are often your highest cost group, and really you want to try to bring them in. So you have to decide, if you're going to make this work and you want to reduce your overall cost, how are you going to address that group? How do you attract them in? What are some issues? The other places, where are you going to put the center? If you put it in the middle of the factory floor, people can't get to it if they're not under secure situations. Maybe you have some confidentiality issues, some safety issues. So where you put it. So all these things might cause you to determine what your options are. David, services?
Yeah, so I think there was a prior slide that hit it, that sort of touched on this. These are the common services we're now seeing in worksite health centers. Probably, again, a lot of these are familiar to you. Couple that I will spend a little more time on. Behavioral health we talked about, so that's a pretty hot area. I think employers are really sort of trying to figure out, the integration and in some cases, the tension between a virtual behavioral health solution, which they may already have, and the value of having on-site behavioral health. Probably up until 5 years ago, many employers we talked to had this idea that there would be a stigma associated with employees coming and seeing a behavioral health provider at a worksite health center. And ironically, as we started putting, but some employers felt, oh, we need to do this, people will figure it out and understand it. And if they don't want to use it, they won't use it. So as we started putting behavioral health on site, what we found was that the most heavily utilized service was behavioral health. And it wasn't a question of were people using it. It was more of a question of when can we add additional resources to this. So we found really kind of the opposite of what the conventional wisdom was on behavioral health. And that's not to say it's a fit everywhere. We have some clients and employers that are very opposed to putting it on site for a lot of different reasons. But where it's been tried, there's been tremendous success with it. Physical medicine is another area that has gained a lot in popularity over the last few years. So physical therapy is an ancillary service that makes a lot more sense. Well, they all make sense if you've got a lot of volume of visits, right? But where we typically would see that would be a population with a lot of musculoskeletal claims. What the interesting thing is with employers that have a lot of manual labor jobs where there is a lot of musculoskeletal and quite a bit of occupational health musculoskeletal. In those situations, we'll typically find that there is high musculoskeletal in the medical plan. So the question is, what's going on? Why is that associated with the medical plan? And if you drill down into the data, what you often find is probably a lot of what's coming into the medical plan is repetitive motion claims that have accumulated over the years, or maybe even some claims that should have be over on the workers' comp side. So we've had good success with physical medicine, again, where it's been introduced and where it pencils out well. There's been high utilization. Chiropractic care is, I don't know how people on the call or anywhere feel about chiropractic care. I remember there was a big chunk of my career where chiropractic was considered a dirty word in the medical plan arena. I don't think that's the case anymore. And whether it is or not, in a lot of geographies, there's heavy usage still of chiropractic care. Where that's been introduced, there's been very heavy utilization of the chiropractic care. Again, I think it's an access situation. So those are some big opportunities. I mentioned RX dispensing. We've gone from formularies, on-site dispensing formularies of 25 or 30 meds to very commonly seeing, 150, 200, 250 medications, moving from acute only meds to chronic meds. There are some significant economics that I think play into that. There's some gains potentially with adherence when you're delivering it all in one location, and the primary care provider is pretty involved in the medication dispensing. So again, we're seeing significant expansion in the pharmacy arena. Occupational health, again, it's going to be kind of what fits the employer situation. So you're typically with OC health centers, you're looking at manufacturing or production or transportation environments. So we work with occupational health clinics that kind of run the gamut from injury treatment triage to pre-post employment physicals using job simulation to environmental surveillance and safety. So,
Great, thanks very much.
yep.
David?
Yeah, so this is maybe, I guess I could call this the money slide, if you will. So one of the core services we provide to clients is doing financial feasibility studies for them to see, what pencils out, what's the ROI. We start with more of a holistic view of ROI. So let's call that VOI, which includes things that are really hard to quantify. And so we discuss those things a lot, and the employer wants usually to do at least some qualification of that. But typically our work boils down very quickly to sort of monetizing savings and costs. So this is a little slide that I've sort of developed over the years to kind of talk about, well, how do clinics save money? Where do you get the ROI? And there's a number of areas. I think a lot of employers go into this thinking, well, we're gonna do primary care visits in the clinic. We're going to replace those costs in the network. We're going to do some RX in the clinic. We're going to replace those costs in the PBM. We may do some ancillary services. But in our experience running these, we do some pretty sophisticated modeling using claim data and risk adjustments and things like that. But what we have found consistently over the years is it's difficult, if not impossible, for a worksite health center to save money just by replacing network services in primary care with clinic services. You really have to be able to expand beyond that to garner savings in other areas. And so this kind of really speaks to that. So, the first thing we got to do is get people in the door. We've got to get them to use the health center. We do that by, trying to create a lot of access modalities. We do coaching in the clinic. We do a lot of patient education. So whatever we can do to get people engaged, that's going to drive utilization of services. And utilization is probably the most important single variable in generating ROI. We've talked about lower unit costs, so that's just displacing some of the primary care services from the network into the clinic. Some other things we do, though, that are really important to savings is we shift treatment settings. So we are reducing ER visits, usually significantly, by having an employee health center that can do same day and walk-in appointments and where there's strong technology access. So we can do a lot of that because a lot of ER visits are casual and shouldn't be there. We also find that we can reduce a lot of specialist visits. So people who are self-referring to specialists, we can often use the clinic providers to really provide referral management and care coordination to make sure that when somebody does use a specialist, it's a really cost-effective and needs-based activity. We eliminate redundancy in the system. So we do that through referral management, care integration, so that we don't have 3 different people ordering largely the same lab and imaging tests, et cetera, et cetera. Where you get a lot of bang for the buck is using the health centers in population health management. So this is not only some of the coaching and self-care, but also really it's kind of the work of the primary care providers who work with a patient, again, in a really holistic way, looking at all of their health needs and trying to fill gaps in care. And by doing that, you're going to drive savings in specialty and facility care. And so what we find when we do the modeling is typically a third of the ROI from any given clinic is driven over time by reducing spend in these areas. So that's a really important component. And then lastly, when we do quantify savings, we're kind of looking at three things. HEDIS scores, you can't exactly quantify a reduction or an increase in your HEDIS metrics to savings. That's kind of where you have to rely on, some good old fashioned good faith and good process management. So that's a really tough thing to quantify. But what we do is we really try to look at total cost of care for the patient on a risk adjusted basis, and then be able to compare that either over time or to compare it between the health center and community-based care. So to the extent that you can really drive some savings in total cost of care, that's really going to pull in a lot of the work into monetization that you've done in the population health arena. Just in terms of our modeling, again, remember, when you put in a health center, you're typically going to get, if it's open to dependents as well as employees, on average over 5 years, you're probably going to get 30 to 35% of the PCP visits coming into the health center. So when we quantify that, a lot of clients want to know, okay, if I put in a health center in this location, what's that going to save me on my medical trend? So we're pulling in everybody into the base, meaning the users and the non-users, the people getting PCP, a care from the clinic, as well as those just using it casually on an acute basis. And so when we look at it that way, we're sort of reducing trend usually 3 to 6% a year based on the modeling we do. If we just look at people who are using the clinic for primary care, then we see a much higher savings. So typically it's running in the 15 to 30% range. And again, just to level set here, we're looking at total cost of care on a risk adjusted basis and comparing community care to worksite health center primary care. But those are the kind of the numbers that pencil out. Larry, there's another source. There's some other sources of data on this. I know, Mercer has historically, done survey work, some of it with NAWAC. And the ROI reported by employers with health centers as, kind of typically pencils out in the 2 to 1 range, or maybe a little higher, but then that's pretty consistent with what we see.
Okay. Due to our limitations on time, I'm going to just show you other slides that we'll send you after this session, but I want to get to the roundtable. So I want to give you a quick overview on some other things. So David's talked about the savings, hard and soft savings. That's really key. You have to understand when you're making your business case where your costs are. These are the 4 or 5 major areas of cost: the space, the staff, the administration, supplies, and communications. As David said, the ROI can vary, but I really encourage you, if you're going to get into this, do measurement. We found in our last study that over 50% of employers didn't even measure their ROI. You can't get additional resources from your C-suite unless you know what's going on. And these are the kinds of ROI that have been reported to us. Clearly, knowing your upfront costs and the initial investment, you're not going to recoup this stuff in the first year. But the other kinds of things that you can recoup, as David's mentioned, I'll talk to you in a moment. But knowing what your costs are in the key areas, making sure you and the vendor both have identified those costs, that you're building that in, but your total costs are the upfront costs, the operating costs, and any other kind of investment. And then it's not going to happen in 1 year. You got to figure out how long. It could take 3 to 5 years to recoup some of these upfront costs that you might have. But you can have savings. You can show a return in other areas. Clearly, how many people are involved, how many people are using a clinic, where you're going to use it, who you're going to allow is going to make a difference. And when we talk about VOI, this is the areas that I suggest. So you want to be able to report back to your C-suite or your board of directors or whomever on these kinds of things. As David mentioned, you could reduce your emergency room use for non-emergency reasons substantially within 12 months. You can increase your A1C scores. You can increase your flu immunization rates. You can increase your satisfaction rates. So a lot of things you can set up to get returning, show return, and set the appropriate expectations for your senior staff in those areas. Other areas are going to take longer periods. So the lessons that we have learned is you want to use worker surveys and focus groups to see, are people going to use it? What kind of services that they're going to want? So you build that into your business plan. You want to analyze, you want to look at your claims and pharmacy data. You got to promote confidentiality or privacy or people won't use it. You got to make sure that providers are people that understand your culture, your benefits, the physical needs, and really fit in. Because if you have bad providers, it'll kill the clinic. These things close. They close for bad communication, bad providers, bad marketing. You want to offer it at free or lower cost. You want to create metrics to add your objectives. So if you have an objective of having a certain number of people in, you want to measure that. Don't end up at the end of the day, and make sure you build these into your RFIs, not just your RFPs or final contract. Whoever you work with as a partner has to agree to meet these things and be able to report. So with all that, let's kind of go around the table and get people's thoughts and questions. And I'm just going to do it based on how you show up on my screen. So I would ask that you unmute, and then I'll ask for your comments and questions. So let's start with Melanie Small. Melanie, if you would give us your thoughts on any questions or comments that you have, and then unmute yourself.
Sure. Can you hear me okay?
Yeah, go ahead.
Okay, great. I appreciate this because I think a lot of us, I work for Intermed. I also provide services in an on-site clinic, and it's we know a lot of this, but trying to get our hands around it. I think what David was saying earlier really resonated with me around it's hard to get those soft costs. So just sort of putting it together in a big picture way, I think is a very helpful way to look at it.
Anything you'd suggest that people could help make the business case?
I think what we've learned, which is just going to reiterate this presentation, is that it's all about the chronic disease. It's all about getting people screened and getting the cancer screenings and things done for people, because not only do people, at least in our area, our demographic area, not only do they have difficulty getting access, they can't afford to go. And so because they're not going, even though they're supposed to have a free physical, they know they're going to get coded and they're going to get a charge. So they're just not going. So we're trying to fill that gap, and we're finding that that's been very successful.
Great, thanks very much. David, we have a question from Laura Spalding, who wanted to know, when employers are using a clinic for primary care and occupational health, how have you seen ROI blended when it's typically very segmented?
When it's typically what?
Segmented, separated.
Yeah, great question. So I'll just tell you what our experience has run, generally speaking, when we are doing ROI on both areas. But again, it's going to vary, obviously, depending on the scope of the solution for each of those components. But if you have a typical primary care worksite center, meaning you're doing full primary care, plus at least the kind of embedded ancillaries like lab and medication, coaching, things like that. If that's the primary care situation, then if the occupational health situation or services are, I'd say the most common thing to do would be to limit them to areas that aren't going to present potential conflicts of interest, where you've got providers doing both occupational health that involves determining return to work or leaves of absence, things like that. So really that means you're doing injury triage and basic treatment. You're doing anything pre-employment, so it'd be drug screens, pre-employment testing, things like that. I would say that typically the add-on for the combined clinic is that the occupational health typically adds savings of like 10 to 15%. Okay. If however you have a really large center And let's say you're doing both OC and primary care, but you found a way to segment that so you're doing really full scope services in both. Then typically, if you're doing things like post-offer employment testing, using job simulation techniques, and doing a lot of the workplace ergonomics. So that means that you're identifying you're identifying areas that are generating a lot of injuries, and you've got specialists working with the line people to really figure that out and make corrections. I would say the occupational health center can add as much as 25 to 30% if if their incidence of claims are really high, things of that nature. Clearly, the primary care from a savings standpoint drives the bus because there's just so much more medical spend than occupational health spend, but those are some of the ratios that we've typically seen. Does that
Great.
answer your question? Is that helpful?
Yeah, that's great. Thank you.
Okay.
Leanne Henderson, unmute please, and your questions or comments or thoughts.
Good afternoon. We are an employer with about 14,000 employees, and we are in the making the business case stage of an on-site clinic. And I think one of the key questions for us, if anybody has any feedback on how they've handled this, is that there's a strong conversation around social determinants of health and ensuring our community, we're a local government, so ensuring community members have access to care, but also that kind of ensuring that employees have access to healthcare as well. And so we're trying to kind of, I don't want to say leverage, but perhaps leverage that discussion to make the case for a worksite health center to enable that easier access and more convenience to care and lower cost care for employees. I was just curious if anybody had experience using that particular discussion point in the argument for a clinic.
Well, I would say absolutely. We've heard it among a number of people. It's really all about health equity. How do you ensure access to care for people who are low income or in remote areas or areas that don't have the kind of services that you're seeking? These centers can, again, provide that medical home for those individuals. About 60% of our employers do not charge anything for people who use the center and the lab services and the drugs that are offered there. About 40% do charge. They do it primarily to make sure people show up for appointments, but there hasn't been that issue. And of course, the issue with those would have health savings accounts, that's a different story where I have a mandatory copay, but we've convinced the IRS not to identify what that mandatory copay should be. So we find that people charge as little as $10 and as much as the network under the network provider rate, the average rate about $33 for a fair market value fee. But health equity, giving people access really is a driver, and I think could be clearly used. The other thing is we found some of our employers who have very diverse populations is they've been able to identify by type of population, by demographic, by color, by culture, the use of the center people, the use of certain services, and they've been able to enhance and increase those services for populations in those locations that have that kind of need. Anybody else want to comment on that?
I just have maybe one thing to quickly add. So just building on what Larry said, we've had employers really take a very proactive approach around that, to the point where they resource roles in the health center to really serve as a proactive advocate for individuals that have needs, helping them find community resources to handle whatever situations they might have that are in the way of them getting the proper health care, helping them find affordable solutions that maybe aren't covered by the plan, looking for if they've got for taking some really heavy duty medications, looking at potential 340B options. So there's a lot of ways I think that resources can assist employees and dependents, with really making the most out of resources that are available to them that may not be, strictly speaking, within the scope of a typical clinic or a typical medical plan.
Thank you, Dave. Mike Osterban, comments, questions for you?
Yeah, so I have kind of the opposite problem where the executive office is more in line with wanting to start this. However, we come from a very strong union background, and it's trying to get the unions and the workers more on board with it. So I'm wondering, from the opposite standpoint, do you have any tips to try to get employees to engage with it and get some higher level union leadership to be more on board with this?
So, I mean, I'll comment, David, I'll turn it over to you. We do have unions who are members of ours. Clearly, the unions want to have some control. Often they're involved in negotiating. Maybe collective bargaining has impacted the kind of benefits that are being offered. Again, I think focus group surveys, including them, perhaps there's a labor management committee that can be brought to this to talk about this, what services are needed, what are people having trouble with, where are the high costs. They have both the, as David mentioned, identify the employer and the employee needs, both on financial and access wise and productivity wise, and then have a joint plan. Though we have, again, as David mentioned, the culture of the employer is really key here. There's some unions that don't want anything to do with the employer, and they would want the on-site, or not, they won't want an on-site center. They want it distant, away, at least a mile away. Some employers recognize that, and they won't call it Acme Metals Wellness Center. They'll call it they'll adopt the name of the vendor, St. John's Wellness Center or Premise Health Wellness Center, and they don't want they're connected with it. Others, I've seen the centers next door to the HR office. They're not concerned about confidentiality or privacy. So knowing the culture is really key, but then bringing them into that early discussion and again, surveying them, focus groups would help. David, your thoughts?
Yeah, great comments, Larry. So here's the way I kind of see it just from a client perspective. So I work with employers that have what I call major unions where the employer sponsors the health plan, runs the health plan. And I'm thinking of like, United Auto Workers, Steel Workers, number of very large unions that are not in the mode of running their own employee health plans. So I think with them, a lot of them have really come around. And so if a particular local chapter is really skeptical, I'm sure they're probably by now, I can think of a lot of good union examples where there's been, great collaboration between the employer and the union. I have a client where there was tremendous collaboration. I'll name the name here. It's Volvo Trucks. We put the first clinic in at Volvo like 11 years ago. The union actually wanted the clinic. They were the proactive party in doing it, kind of dragged management into it. So from the get-go, it was a very strong collaborative arrangement where the union was very involved in a lot of the decision making around what services would be provided, what would the hours be. Because if the union, if it's a union employer and the union is either not supportive or worse, they're undermining it, you're just not going to get the utilization. It's going to be really hard to make the thing pencil out. Then the other track I'll go into are unions, Teamsters, a lot of trades unions where the union is really sponsoring the health plan. So the union runs the health plan. We see a lot of Taft-Hartley plans that are migrating to shared centers. I can think of a lot of examples where that's the case. So again, I don't know what your particular situation is, but I think I've seen a lot of really successful examples of union employer cooperation. But I think the only way it's going to work is if the union is involved to a significant degree in figuring out what's going to really work for their members.
Does that help you, Mike?
Yes, it does. Thank you very much.
Great, thank you. David, we have a question. Do you believe on-site and near-site centers are on the rise? Or are they declining? Is the market saturated? What's the trend and direction?
Yeah, so if you look at the trend data, like if you look at a large employer trend data, like National Business Group on Health, I think the slope is pretty slow. It's up in the 50% range, probably meaning that a lot of these major employers have already looked at this and they figured out it's either a fit or not a fit. So where it's a really large employer, while we do still see some brand new clinics, I would say we're working with those employers a lot more on optimization of existing clinics. In the mid-market, there's really been an explosion, and I'd say kind of a second explosion. So we had an initial number of adopters before COVID, but as soon as I'd say after a year and a half or 2 years after COVID, we started to see a lot of re-engagement, particularly in the middle market. So I would say the slope is high. The percent of employers that have adopted clinics is lower than the major employers, but it's growing faster. And some of the industries that have really been growing very rapidly, government sector, a lot of growth in government, a lot of growth in healthcare workers. That's been historically a really tough nut to crack because healthcare workers find other ways of getting healthcare than what you and I typically do. That's been a little more challenging. We've seen a lot more growth in healthcare workers. And I would say manufacturing employers, mid-sized manufacturing. The spend is a lot higher than it was 5 years ago. So there's a lot more potential ROI dollars on the table. A lot of those employers really suffered during COVID, getting people back to work. Typically in the mid-sized employer, there's a lot of interest in primary care plus OC. And again, as I think I mentioned earlier, OC health clinics have definitely grown in terms of scale and interest. So.
Yeah, and I think in our perspective, of about a third of all employers have some form of on-site, near-site, or shared center. With shared centers, network solutions where you have multiple centers around an area shared by multiple employers being the fastest growing area. The other thing that we learned is we thought during COVID it would kill a number of centers, but our own surveys show very few employers closed their centers. They moved to what I call a click and mortar strategy, where they identified the virtual care services was much more valuable. And now, particularly for our hybrid populations, being able to offer in-person and virtual care in a single center really increases utilization, increases the value of the center. We have a few minutes left. I'm going to try to go around with people who are still on the call. Tony Musi, any comments or questions you have, Tony?
Thank you, Larry. This has been a terrific discussion. Thank you. And it also, seeing Megan McHugh reminds me I didn't respond to your email last week, so that's coming today, Megan. Quickly, I guess I'm on the provider side of all this, and I'm curious how David would respond to a clinic provider who wants to know what are the main opportunities they may be not thinking about or missing out on, maybe in the context of ROI, but also maybe separately in a more warm and fuzzy context of keeping a strong relationship with their client.
Go ahead, David.
So I guess let me take a whack at that, and I'll see if it's resonating. So without knowing exactly what scope of services you all provide, I'll kind of run down what we're seeing with other worksite providers that we work with or have recently worked with. So I'd say the biggest growth or expansion areas have been, and not in this particular order, but these are like on the top of the list. I would say virtual healthcare, and it's not just virtual primary care, it's providing access to virtual anything and everything. Now, a lot of that you're going to outsource to other specialty providers, But I think this whole area, before COVID, the worksite providers were just beginning to get into point solutions, providing point solution access. The challenge has been that, a lot of employers already had point solutions for diabetes or behavioral health or after hours care or whatever. So is always trying to figure that balance out. I think, people have sort of settled in on what they want to focus on, but most of the larger worksite providers I'm familiar with do have point solutions that they can offer if the employer wants to use those instead of whatever they've got. And there's in the mid-market, there's still a lot of employers that don't have point solutions. So again, that's a big area of growth in the mid-market. Occupational health. So some of the really large worksite providers, who I won't name, they didn't really have a significant offering in occupational health. They all had some clinics where they did some occupational health. I would say it was largely limited to treatment and triage and drug screens, but they really weren't doing a lot of the heavy lifting around post-offer employment testing and ergonomics and health and safety programming, things like that. But a couple of the big ones have really upped their game in the last couple of years. I can think of three major providers that really upped their game. One major provider who didn't do anything in the Aux space, but had some amazingly large clients. They had some amazing, really large clients. They just started doing occupational health. So that's something we've seen. Physical medicine. I'd say a lot of clinics are offering physical medicine and behavioral health I mentioned earlier. So those are probably some of the key areas that we've seen significant expansion in the last few years by a number of the largest worksite providers. Does that help?
Right.
Did I get there? Did I answer that?
Yeah, absolutely. Thank you, David.
Okay,
Go ahead.
Great. Thanks very much. Let's move on. Sarah Fry, comments or questions? Sarah? Sarah, take yourself off mute. Okay, Nicole Bitter. Nicole, any comments or questions?
Yeah, question and a comment. You, David, were talking about mid-size market. What do you consider the mid-size market?
I would say, from my practically speaking, we're talking about employers that are 500 employees to 5,000 employees. If you want to open the discussion up to shared clinics, then I think we can be talking about a lower number for employee counts. But the idea with a worksite health center is, I think, in order to really have it be considered by the employer dependent to be their medical home. If your goal is we want to change the game in chronic disease management and population health, for it to be considered their medical home, I think there needs to be access at a certain minimum number of hours. And if you want people to use it for acute care, then you've definitely got to be open, I think, at least 30 hours a week. So when you start to put those parameters around a 30 to 40 hour a week clinic, I think 500 is a good sort of benchmark number for what you need to make the thing pencil out to a good ROI based on our experience.
The last thing you want is providers sitting around not seeing anybody.
Yeah, exactly.
Well, we are a provider of on-site healthcare 360 medical, and interestingly enough, we're chiropractic led, and we see that all of our clients, MSK is their top 3 spend in healthcare, and that is in our clinics that we open is what fills up first.
Yeah.
Is the musculoskeletal component.
Yeah.
Right. Thank you very much. Let me move on
Thanks,
quickly. Sure. For those who want to stay on, David, if you've got another 15 minutes, we'll try to do that. Jennifer Moore, comments questions? Take yourself off mute. Jennifer?
No questions. I think this has been very helpful. Here in Ohio, we have several on-site clinics at the employer site, and they vary from acute care versus complete occupational health and surveillance services. We have talked about near sites because one of the trends we're seeing with some of the employers locally is, they're trying to save cost, and we're just trying to cement the information on, our return on investment. We do provide them with quarterly reports, but I'm seeing a lot of employers having to make substantial cuts, and some of our clinics have been challenged with that. So we have talked about near site proposals, but we currently don't have any up and running currently.
Understood. Great, thank you. Greg Stefanik. Greg, any comments or questions you want to add?
Thanks for the information, Larry. David, great job. I practiced medicine under this model for 4 to 5 years, and it's a wonderful way to practice medicine. I'm curious, though, we still had trouble recruiting physicians sometimes to this model. Do you have that concern in some of your on-site clinics? That, again, is just a wonderful way to practice medicine.
Yeah, well, recruiting's been a lot more challenging everywhere for everybody in the last few years. I think what we generally have experienced is in a major metropolitan area, it's usually finding good providers has not historically been a problem. I still don't think it's that much of a problem. I think where it gets more challenging is when you get down to the nursing staff, but I'm gonna caveat that by saying that everywhere is more challenged than it was 5 years ago. Okay, so the challenge level is definitely ratcheted up, but I think for a clinic situation that's reasonably good from a provider perspective, I won't get into what that is exactly, but where it's a clinic where they can practice medicine at the top of their license. They're not going to be bogged down with a lot of administrative details. It's not a challenging physical environment, et cetera, et cetera. I think we are still able to recruit providers pretty well. And a lot of providers really find this a more attractive way to practice medicine compared to community-based medicine, where they have to see 25 or more patients a day. So.
Great, thanks very much. Jeffrey Kessler. Jeff, any comments or questions you want to make? Take yourself off mute, Jeff. No? Okay, Megan McHugh or Maria, any comments or questions you guys have?
Good afternoon. Thank you, Larry and David, for a terrific session. I do have a question for you. So we at Northwestern University are doing a systematic review. It's a study looking at the economic analyses of worksite health centers. And we're specifically looking at worksite health centers that offer more than occupational health, at least some primary care. And this is being led by a doctoral student, Maria, who's also on this call. And so we find it really easy to find articles that have been published in the peer-reviewed literature on the ROI of worksite health centers. We also know that there are some organizations like Premise Health that have some company-specific ROI materials on their website, which is awesome for us. However, my question for David and others is, do you have any suggestions for us in terms of how we can get our hands on economic analyses that might not have made their way into the public domain just yet?
Well, I mean, I can share some client situations with you anonymously in terms of kind of some of the things we're seeing. I think we would and maybe this could be an offline conversation if you like, but I think if we can sort of, if I can just get a better feel for exactly what you're looking for, I think I could probably help give you some information. There is a lot of, yeah, I mean, so that's the only thing I would probably have access to besides whatever's sort of out there. And maybe there's some stuff out there in the published world that you haven't seen yet, that might be interesting, but are you specifically focused on OC or are you
No,
focused?
we are not specifically focused on occupational health. We're really interested in worksite health centers that are doing at least some primary care.
Okay.
And I
So there
appreciate
are
that.
some-
And I'll reach out offline. We are not interested in compromising any of your clients' identities. We don't need actual names of companies, but we want to understand how folks are actually calculating ROI.
Yeah.
And of course, we will make our analysis available to this group.
Yeah, so we work with some universities that have both and definitely have primary care. I'd be happy to talk to you offline if that would be of interest, and I can perhaps share some information that might be useful to
Thank you.
So
Yeah,
feel
just
free.
copy me on that as well. But I would tell you, Megan, we have a number of conferences, presentations where employers have provided their own data on economic and health outcomes at open meetings. I mean, these are not published in journals at all, but they are provided, and it's more than anecdotal. They do their own analysis and they come up with, but they have their own approaches to, what's in the numerator, what's in the denominator for that. But yeah, I'd be glad to help you and Maria go through that with our own resources here too. All right, thank you. Moving on, Joe Brontino. Joe, any comments or questions?
Sure, go ahead. Larry, I thought
Yep.
one of your comments on the early part of the slide deck where, primary care being seen on site, they see their primary care for 7 minutes once or twice a year, but they work 2,000 plus hours on site every year was a pretty powerful statement. And we're trying to leverage that. We opened a center where we started with nurse practitioner coverage 3 days a week. And then within the first 4 months of being open and on site, our corporate partner asked us to go 5 days a week with our nurse practitioner service line. They saw that value of accessibility pretty quickly. So we're trying to enter more of the primary care space because right now it's sniffle sneezes, more urgent acute care versus chronic disease management, which is really where I see the largest opportunity for us to grow into. So I thought maybe I'd just present that to you and see what your thoughts are for an employer who is initially not eager to enter the primary care space, but more managing the acute or urgent care type nurse practitioner. We also 360 are in the musculoskeletal space, which Nicole mentioned as well.
Yeah, well, I think again, the easy low-hanging fruit for worksite centers is stopping the utilization of urgent care centers and emergency rooms for non-emergency reasons. I mean, the emergency department of a hospital is perhaps the highest cost setting in the entire healthcare industry. If you could stop people from going there and not stop, prevent them from going there, but offering an option at work that they don't have to go after work or on off days or weekends. And then if a simple computation, and David, this may not be appropriate or not appropriate, but statistically credible, but you figure what's the average salary of the people in this company or that section, times how many people are leaving and how long are they gone. You multiply that out, you can see the loss of income of wasted payroll that you have when people are leaving to go to emergency rooms and urgent care centers. So being able to demonstrate that shows a real return very quickly. And again, in addressing primary care, because if people go to a hospital emergency rooms for primary care, for immunization screenings, etc., and urgent care centers are beginning to expand. The urgent care industry is interested in being primary care centers. And so they're offering more and more operations there. So being able to offer access to these kinds of services, I think, is really a key. Hope that helps you out. Let me move on. Jeff Kessler. Jeff, again, any comments or questions? Okay. Tony Perky, Tony, any comments or questions? Tony?
Well,
If
that was
not-
perfect timing.
Go ahead.
I have a gas leak at my house, and so the gas
Oh, my.
guy was like talking to me. So I missed a few parts of it because of that, but I'll say just the things that I've seen over the years is like we talk a lot about the general concept, but remember that every situation is unique, and that's why you use consultants, right? Is to come assess whether it's bad access in your community or poor quality care in your community, or high claims on this, high claims of that. Like, you just got to make each situation, and remember it's unique, and there's not one perfect fit for every single situation.
Sure. Well, thanks very much. So David, I want to thank you for your time and your contribution to the group. I want to thank everybody who participated in the roundtable. And the next month's roundtable on the first Monday in May will be on how do you increase utilization in your centers. So with that, everybody have an enjoyable week. Thanks very much for participating. Look forward to seeing you at a future event. Bye-bye.
Thank you.